Good morning, everyone. I'm Murray Ross with Kaiser Permanente, and I'm pleased to be here to moderate this second session of the conference, The Impact of Federal Debt and Budget on Implementation of the ACA. And as with the other speakers and moderators, I'd again also like to thank Margaret Wong and Paul Feldstein for having me back for, I don't know, is this year 15, Margaret, or something like that. And as John Gable said, this conference is unique, not only in the continuity of many of the speakers, the continuity of the people in the audience, but it's also unique for, it's probably the only conference you'll go to where people laugh with the economists. That was with, right? But I did want to just call out one thing in Jim Baumgartner's thing, because as a former CBOer and budget geek, it's worth reiterating a point he made, that in the next few years, as our interest payments on the debt go up from 1% of GDP to, what, 3.5% of GDP or something like that, we're basically adding the equivalent of a new federal entitlement program that's more money than we will spend on Medicaid and the health insurance exchange subsidies combined. The only difference is we don't get anything for it. Half the money leaves the country and the other half changes pockets. And the other difference is that's money that you don't control that spending. That's the price of previous decisions. And so when people say, do deficits matter? Well, they do when they get large enough and you actually have to pay the accumulated interest on the accumulated debt. Just a couple housekeeping things. I want to note a program change. Kavita Patel, Dr. Patel could not be with us. She had a last-minute family emergency, so and it was sufficiently last minute that we didn't try to scramble to find a fourth panelist. But as you know, some of the gentlemen to my left tend to go on for too long. So we will make good use of that time. But more than that, I'm actually hopeful that we'll have a fair amount of time for question and answer. The other is apparently we have about 100 people in the overflow room, wherever that is in this building. So I just want to say hello to them and welcome to this session. After lunch, I know many of you are comfortable in the overflow room because you have tables and wine and cheese brought to you. But if you do want to come into the live room, it's here. So I'm not going to belabor the setup because you've gotten a good amount of the setup in that first session. But as I was thinking, so what happened in the year that's gone by since we last convened? And this confusing interplay of politics and debt and deficit policy and health policy continues. And I have to say it's really hard to keep track and to make sense and to figure out what to do. And we have had some lessening of the overarching uncertainty, I think, but we're still moving into an era of real programmatic uncertainty. We had the Supreme Court decision. On the one hand, it locked in and said the individual mandate was constitutional. On the other hand, it struck down a provision of the Medicaid expansion. That creates some uncertainty about how states will respond. We had an election that basically resolved uncertainty about whether the Affordable Care Act would stay in law going forward. But at the same time, on the budget front, it returned all the same players to continue those same discussions they'd been having so successfully to that point. We had the fiscal cliff at the end of the year that we successfully, negotiated our way down the cliff to this new plateau, and then we have the sequesters kicking in next Friday. Unparalleled times. But two big issues that we are going to touch on in this panel, well, we're going to do more than touch on. We're going to spend a couple hours on it. One is Medicare, and what do we do about it, and how do we put it on a sustainable footing, both in the long term, but also in the short term. And then the second is the Affordable Care Act. John Gable asked, would you vote for smooth or chaos? I think we know the answer lies somewhere between those two poles, and probably most people would edge towards it'll be pretty rough. But it will continue to have some political attention paid to it, but then there's still a whole lot of action. I know you'll hear more about that in later sessions today of actually getting it done, getting it in place. And by the way, it's not January 1, 2014. It's October 1, 2013 when we start to have open enrollment for people to sign up. So we're 7 months away, not 10 months away. So without further ado, let me welcome our first speaker, Joe Antos, and I won't go through the biographies, they're all in your packets, other than to say he's the Wilson H. Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute in Washington, D.C. Joe's an economist by training, and he has served at the full federal alphabet soup of agencies in Washington, CBO, OMB, CEA, HHS, and now AEI. So welcome, Joe.
Thanks, Murray, and thanks, Paul and Margaret, for inviting me back, especially given my tendency to overuse my time. Let's see now. Where is the? Here it is. Okay. I can see it here, and I can't see it there. How do you get the first slide up? Excellent. Thank you. Okay. So, as Murray said, and as you all know, this is a year that is particularly fraught with uncertainty. I think it's exceptionally so. If anything, I think perhaps the Supreme Court decision, I don't think it reduced the level of uncertainty. It just moved it around. And I'm not going to talk about the Supreme Court decision. That was then, and this is now. And as John Boehner said the day after the election, and actually contrary to what you hear an awful lot of commentators say these days, John Boehner actually did say that the ACA is the law of the land. But that wasn't just some, platitude. What he meant was that it's the law of the land, and at least in terms of politics, it's not going to change. Things will change about it, but Congress is going to be unable to make even simple corrections that everybody would actually agree to, because that's politics these days. So I think that's an important point. But I'm going to mostly focus on Medicare. I mean, there are all sorts of uncertainties. Most of us feel a little uncertain about the economy. Jim Glassman being probably the only exception in the room. Health spending, we've got some good news lately, but we don't know whether that's going to last. The implementation of the Affordable Care Act is, of course, uncertain at every conceivable level because it is a big, complicated thing. It was, many of the provisions assume certain realities that probably don't exist, probably didn't exist, probably will never exist. So it makes it very complicated. And then the ultimate uncertainty, which is the uncertainty of whether Congress will act or not act this year on, frankly, anything. That's an issue. But, with regard to the budget and health spending in particular, is there really no cause for alarm? We've seen some great news from the National Health Expenditures release from the actuaries, and things look pretty good. Or, in fact, is the sky really falling? It doesn't actually have to hit you to damage you. Although if it does hit you, you won't know the difference. So that's, that is the good news of this talk. Okay, so let's see, I'll get to serious. Okay, so the first question I have is, has Medicare turned the corner? These are our data points from the National Health Spending data that the CMS Actuaries Office puts out every year. This comes from the January 2013 article that they put in Health Affairs. And what you can see is that good God, did I fail to put the years? No, the years are there. Okay, so you can see that in terms of spending is the blue, I think that's blue, is the blue line. And what those percentages mean is how much did Medicare spending in total grow from the previous year? And then the red is GDP. How much did GDP grow or shrink because of the recession from the preceding year? So you can see that 2008, 2009, in terms of health spending or Medicare spending, is really the way it has pretty much looked for quite a few decades. Medicare spending has traditionally always grown much faster than the economy, even when the economy was doing very well. Obviously, much faster than the economy when the economy was shrinking. But then 2010, we got some good news. Good news in both regards. Medicare spending, the growth rate dropped significantly. And this is on a per capita basis. And GDP per capita grew substantially, certainly compared to the recession year. And then in 2011, the picture seems to have more or less repeated itself. Now, why do people in Washington focus on per capita spending in Medicare and per capita GDP? Well, you could say there's an analytic reason, but I suspect that there may be a political reason, and the political reason, of course, is in the ACA. The Independent Payment Advisory Board, the IPAB, has a target to keep Medicare spending at or below GDP plus 1%. Last year, the president, in his proposed budget, offered to lower that to GDP plus 0.5%. So to make that plausible, or even better, to make that painless, what you want is the economy to grow rapidly, and you want something to happen to Medicare that Congress doesn't have to take the blame for, that reduces the rate of growth of spending on a per capita basis. Now, the only problem is you look at those lines down at the bottom, what you do see is that even in the good years, 2010 and 2011, that total spending in Medicare continues to grow faster than GDP. Again, even in years when GDP is growing pretty rapidly. So what does that tell you? Well, as we know from ninth grade, 2 points determine a line. You can see the direction of Medicare spending. Now, I'm going to move to another slide here in just a second that you might think refutes that. But I think the overall message that I have is that it's too early to have a parade down Main Street declaring victory over unnecessary health care spending. And it's certainly too early to claim victory over healthcare spending in general, unnecessary or necessary. So the question, a political question, is this GDP plus 0.5% figure, is this feasible in that political sense? And some people, Bob Reischauer, former CBO director, now at the Urban Institute, is very optimistic that that is achievable. I'm cautiously pessimistic. But I hope it is achievable, but I don't think we have a clue right now. Okay, so what about the new CBO baseline? It says this money in the bank. Well, certainly the New York Times pitch is that it's money in the bank. The New York Times said on February 12th that a sharp and surprisingly persistent slowdown in the growth of healthcare costs is helping to narrow the fiscal deficit, the federal deficit. Well, yeah, in the sense of making a forecast. But did it actually lower the deficit? Well, actually, yes, to the extent that we saw some declines compared to the past in the rate of growth of Medicare spending in the last couple of years. But most of the talk is not about the past. Most of the talk is about the next 10 years and all of that money we're going to save. I thought it would be useful to show you the difference in CBO's judgment. I was going to say opinion, but that would be wrong, about the trend in Medicare spending. So this compares is that 9 years? Or is that 10? I guess that's 10 years. The 10 years of projections that overlap between last year's baseline and this year's baseline in Medicare. So you could see that over the period 2013 to 2022, CBO projected that total Medicare spending would grow by about $7.7 trillion last year, and this year, $7.5 trillion. So that sounds like good news, but remember, this is a projection. So that's about a $200 billion difference over 10 years, 2.7% reduction. So if CBO is right, that's good news. But, these are estimates. All estimates have confidence bands around them. And we're basing this estimate, and it's really a judgment, on only a few years' worth of data with some hints that maybe something's going on in the private sector. I think it is. I don't think it has anything to do with the government, at least not so far. But I think the private sector has been responding to some pressures from employers, from some pressures from the perceived threats of politics. So I think that things are going on. But again, is it too soon? I think it probably is. By the way, when did CBO start changing their mind? I think this is an interesting question. So this is the 2012 baseline that they put out in February last year or March, compared to the one that came out last week. So it's February to February, roughly speaking. Well, they had a different baseline in August. And so if you look in their report from last week, you can see that the total drop from August is something like $140 billion. So in fact, CBO started to reduce their assumptions about Medicare spending at least this time last year, except that it wasn't so noticeable to us. We needed to see another observation. Okay, so what does that say? Well, you've seen this picture. I think without looking at the details, this is the picture we're going to be seeing for now on. The lines will move a little bit, but that's the picture. Medicare's the big spender out in the future. Social Security will stabilize. The other health programs will contribute. This is from last year's long-term budget outlook. And the point of this is not to look at the numbers because they'll have a new report in a few months and the numbers will be different. But what this says is that if you have entitlement spending growing faster than everything else, then everything else has to grow slower. And the only other entitlement other than Medicare, other than the health entitlements and Social Security, the only other entitlement is debt service. And as Murray pointed out, this is the accumulation of our payments on an interest basis for decisions that were made previously. Now, CBO's next report is going to probably increase the impact of demography relative to everything else in driving Medicare spending. Last year, they were assuming that about 52% of the growth, I think a little bit more than that, something like 60% of the growth in spending over the next 25 years would be demographically driven in Medicare. That'll probably go a little bit higher. But the fact is that there's still whatever is left. There's still the 40% or maybe the 35% this year. We still have to worry about spending. It's not just a demographic problem. So now, what's going on in Washington? Is it fiscal terrorism, as some people seem to claim, or is it politics as usual? As you know, a successful terrorist takes hostages. And if you want to be persuasive in demanding whatever it is, you have to be prepared to pull the trigger. And Congress has rarely been willing to pull the trigger, and this year is no exception. So, the Budget Control Act, there was an opportunity to pull a trigger. The trigger wasn't pulled. The debt limit was increased. The default date was moved to, some people think it would have occurred sometime in the middle of February, this month, in other words. The No Budget, No Pay Act, this is also not pulling a trigger. This is pushing this is basically suspending the debt limit until May 18th, which basically means that with tricks that the Treasury Department does, that we won't run into risk of defaults until August sometime, maybe as late as September. Now, by the way, no budget, no pay. So Congress doesn't get paid if they don't produce a budget resolution by April 15th. Well, yeah, not exactly. If that money isn't paid to them, then at the end of the term, it all gets paid back in a lump sum. They didn't exactly pull the trigger on themselves. This was not fiscal suicide for them. Okay, so what about the sequester? The American Taxpayer Relief Act delayed it until March 1st. Again, they're pushing it down the road. Appropriations, well, this is the next exciting event along with the sequester. I think everybody believes the sequester will happen this year. The big question, of course, is exactly how much political pain will it take for Congress to change something about the sequester? In years past, the threat of a sequester or the threat of shutting down the government, people would say, well, we're going to shut down the Washington Monument. But they can't do that this year. It's already closed for repairs. But we already know that DOD has issued a press release, which is not the same thing as an action, that 800 million civilian workers will be furloughed. Now, in the small print, it says 1 day a week. So they're not going to lose their jobs if this really happens. And the question is, will it really happen? Where's the real pain? It is not with federal employees being furloughed. It is with constituents losing their jobs. And so that's my view as to why the defense budget is so important. Yeah, it has something to do with protecting the country, but it has a lot more to do with protecting the votes. And so a good question is, what might happen? When might it happen? And the betting right now is, in terms of appropriations, not necessarily sequester, because there's no clear path there. But in terms of appropriations, that there would be a continuing resolution at the current level, which is the same as last year's level, for all programs except defense and VA. And there would be a separate appropriations that would be higher than that. That's the current betting. And then, of course, physician payment. Will they ever pull the trigger? Should they pull the trigger? And I say yes, because you don't have a credible threat if you never inflict even the slightest bit of pain. And so I think as a political matter, not as a policy matter, as a political matter, the important chairman in the Senate and the House, they want to still have healthcare lobbyists come and visit them and speak nice to them and perhaps leave a check. Well, if you want to just reinforce that discipline, you're going to have to actually allow the SGR to hit for at least a month, and then don't give the money back. Anyway, okay, so potential targets for cuts. I think Bob is also going to talk about a lot of these things, and I'm running out of time. There's the number. Somebody wanted to know about raising the eligibility age. What I can't remember, this is a CBO number, what I can't remember is exactly what were the terms of raising the eligibility age. Jim's right. Depending on how you write the provision, you can either save a lot of money or save no money at all in the 10-year period. It's implausible to me that if we're going to raise the eligibility age in Medicare, that's going to actually bring in that much money, because that assumes that you start moving along pretty quickly. And when we raised the Social Security age, we waited 10 years before the first movement, and that's a sound political lesson. The other ideas that are floating around, there are no new ideas. There were no new ideas truly in the Affordable Care Act. There are no new ideas floating around in budget land right now. There are some new phrases, new names, but the ideas have been around for a very, very long time. As a good friend of mine said just the other night, if you want to reduce spending, there are two ways to do it. And the two ways are, and this is guaranteed, everything else doesn't work. You either raise cost sharing in Medicare to unconscionable amounts, which is defined as more than now, or you can force everybody into a real managed care plan. Now, it's not that they won't get used to it, but they won't like it right away. And I think there's a lot of truth in that. A lot of the other stuff that we talk about is a lot more speculative. Now, I would add to that we do have to change the way we pay providers in the Medicare program. That's very important. But certainly, if we don't look at the beneficiary side, we're sort of missing the boat here. So let's see now. We will eventually return to a more serious discussion of structural Medicare reform. We can't avoid it. In spite of the better assumptions that CBO has right now and the good news for the last few years, nonetheless, the handwriting is on the wall. We are going to get a little bit of a honeymoon because of the baby boomers. The baby boomers, by definition, how do you join Medicare? You turn 65. When you're 65, on average, you're healthier and using less health care than when you're 75. So what's happening for at least a few years is that we're substituting people coming in who are relatively healthy. And, as somebody said something about what's inevitable at the end of life is inevitable at some point. So folks are leaving the Medicare program the only way we know how. And they tend to be sicker. They tend to be higher utilizers for good reason. So we're going to get a little bit of a honeymoon. I don't know how long. I don't know what CBO thinks. A few years at least. But then the demographics work the other way because the 65-year-olds do become 75 or 85, and they begin to spend money. The whole question about fiscal targets, I think, is really up in the air. I would argue that if you're going to change the structure of the Medicare program in a way that's useful, and you're going to tie that to gigantic budget savings, one of those things isn't going to happen, probably both of them. Whereas if you make changes and you lubricate the changes with money, you got a better chance of actually making it happen. The movement to the prospective payment system for inpatient hospitals in the 80s was inadvertently taught that lesson. I'm going to say inadvertently. I'm not entirely sure that it was inadvertent, but it is true that we paid more to hospitals for a few years after that until somebody caught on. And that did ease the transition in lots of ways that were necessary. And that is an important lesson. Let's see. So incentives, I'm an economist. I have to say the word incentives at least once in a talk. I'll just make a point here about who bears the risk. Are senior citizens going to be at serious risk if we move to a budgeted approach to the Medicare program, which I think we will one way or the other? And the answer is they're already bearing the risk. It's just what risk do you want to bear? It's difficult not to just rearrange the deck chairs on the cruise ship HS risk. The fact is that the risk that people like to talk about in Washington is the risk you can measure easily. It has to do with what people pay for premiums or out-of-pocket spending. It is not the other kind of risk, which has to do with access to services. We're all at risk at that. The ACA increases that risk for everybody, but especially the people who are going to be newly insured, because we don't have a lot more capacity right away. I have more to say about that, but let me move on. Clearly, whatever we do in terms of putting Medicare on a fiscally sound path, we have to reform the program. I'm going to say anyway, but in addition. For me, it's in addition. Other people wouldn't agree with that. This is a picture, by the way, of Bess Truman's Medicare card. And the reason it's there is, I happen to find it, but the other reason is that this really does capture a lot about the way Medicare is. In some ways, it's progressed, it's changed, but in a lot of ways, it hasn't changed much from 1965. And so we need to fix that. And there's a lot to be said for example, combining the parts A and B. I mean, you can't be admitted to the hospital without a doctor in there somewhere. You can't buy insurance in the real world unless you're also buying coverage for physician services. This is an artifact of 1965. It does not reflect reasonable insurance policy. There are lots of things that don't make a lot of sense. And we're going to have traditional Medicare, at least for the foreseeable future, in my opinion, no matter what we do. Why? Well, because there are lots of parts of the country where you can't really have competition among health plans. They are, the rural parts of the country, certainly that's the case. So in fact, if you take the Paul Ryan approach to a premium support proposal, Mike Chernow, David Cutler, and their colleague, Mr. Song, wrote in the Journal of the American Medical Association that 75% of beneficiaries would be better off in traditional Medicare. Whatever the number is, that makes sense to me, at least for the foreseeable future. We need to allow Medicare to make some improvements. Okay, so what's going to happen? Well, it's Monty Hall, should come out right now. And, there are 3 doors. So what's behind door number 1? Whoa, wait a minute. Unfortunately, somebody put up the wrong slide. Okay, I'll come back to that. That's behind door number 1. We don't make a deal. We don't do anything. That's the, doomsday scenario. And by the way, he says, if you can't read this, I want you to give me $12 trillion. This is an old picture. So then what's behind door number 2? Well, of course, it's kicking the can down the road, some kind of a small deal. That's what Congress does. If you had to bet on anything this year, that's what you have to bet on. But what is it exactly? That's really tough to know. A lot depends on how long politicians can stand to listen to complaints from voters about the economic aspects of what they aren't doing. So, is it a matter of weeks, months, or years? I'm in the middle. I think probably we're looking at, maybe June or July will be. June probably will be a month where we might see some action to put off the sequester or do something that, adds. How do you put off the sequester? You say, okay, well, just add the amount that we didn't collect to next year. However, they're going to run out of time because everything's on a fiscal year basis, which starts on October 1st. So if you get to August, you're done. You might as, you can't do anything. No jobs will come back in the 2 months that you have left. And so then what's behind door number 3? Well, of course, that would be the big deal of the day if it actually exists. And, it's a possibility, but I'm thinking not so much this year because to have a big deal, to have a grand bargain, it requires compromise. And it's hard to see compromise, which is really, really unfortunate. So what will it take? And I would say disaster is what it will take. So I was actually rooting for our sharp recession. I thought if it would just last a little bit longer, maybe Congress would realize they have to act. But they did act, didn't work, and they didn't actually address our fiscal issues. So we need some other kind of a disaster to drive hard decisions, or maybe another election. Looking out further, we could see major legislation. The tradition in Washington is the president has 90 days, and I think the 90 days are gone. I think maybe it was 90 minutes this year. And by the end of the 90-minute speech, or however long it was, in front of the Capitol, if there was any hope of compromise, I think it was gone by then. But remember, there's another election coming up, and so it's going to be very interesting. If the Democrats take the House in 2014, then the last 2 years of the Obama administration, instead of being sleepy writing my memoirs, might actually be very active, and I think ultimately profoundly difficult for future generations. Thanks a lot.